Good afternoon, everyone. My name is Marc Bernon. I just wanted to welcome you to this Gecko session that's hosted by the Gastro Foundation in association with Project Echo and the University of New Mexico. These sessions are held weekly on a Wednesday at this time. If there are any questions, please post them in the chat. There's going to be 3 presentations, one by myself on strategies to try and increase the number of patients who are getting transplants for HCC, and then Tina Stutoy, who is the surgeon in charge of our liver transplant program, who's recently been on a 6-month trip to Turkey, and he's going to just discuss his experience there with living-related liver transplantation. And then we're going to present a case. Dr. Nicholas Leach is going to present a case if he's finished in theatre. Otherwise, I'll do it on a patient who has an HCC and that we considered for transplant. Okay, I'm just going to share my screen. Okay, so this is beginning. Okay, so like I said, I'm going to speak on our strategies to try and increase the number of liver transplants. When I'm talking, I've specifically got sort of our unit in Cape Town in mind, but I think a lot of this applies to everyone, and also to people who might be considering referring patients for transplant for HCC, or maybe even starting to do liver transplantation. So, as we know, there's 3 potentially curative treatment options for hepatocellular carcinoma: ablation, resection, and transplantation. We know that that if you look at disease-free survival at 5 years, transplantation is the most effective from an oncological perspective, but it is the one that has the highest complication rates and mortality, and it's also limited by the number of organs that are available. Traditionally, these options, ablation, resection, and transplantation, are only offered to patients with early-stage disease. But there is, and we'll talk about it, transplantation potentially can be offered to patients with more extensive disease in selective circumstances. I think it's worth just going through some of the history of liver transplantation as we discuss the changing indications. So the first transplant was done in dogs in 1958. Thomas Starzl, I think, is considered the father of transplantation, and specifically liver transplantation. And he performed the first liver transplant in 1963. None of the first 5 patients survived for longer than 23 days. When you look back at this, you wonder how transplantation for livers ever started, and if we would be allowed to start something like this today. Initial immunosuppression was with azathioprine and corticosteroids, and that was probably part of the reason why the results were so poor in the beginning. And it continued on an experimental basis, mainly at 2 places in Colorado and Cambridge. Up until 1977, only 200 liver transplants were performed. There was a big development in 1979 with the development of cyclosporine, and that really resulted in improved outcomes and a lot more transplants being done. And from 1979 to 1989, Starzl reported a series of over 1,000 liver transplants with a 73% 1-year survival and 64% 5-year survival. During that period, transplants were done for hepatocellular carcinoma, but then they stopped being done because the outcomes were so poor. And I think, well, they were poor, they were worse in patients who were transplanted for other diseases. And part of that was, well, it was mainly related to patient selection. In the 1990s, tacrolimus began to be used. Currently, there's over 7,000 liver transplants performed annually in the United States, and more than 100,000 patients have received a liver transplant worldwide. In that picture, put Professor Khan, who used to be the head of our unit, and I think, he started the liver transplant program here at Trudisco, which at one stage was the only transplant program in South Africa. The other person is Professor Bert Meyerberg, who was head of liver, or head of surgery at Wits in Johannesburg, and he performed the first liver transplant in South Africa with Thomas Starzl, but the outcomes were quite bad, and that program stopped. And transplantation only really started again in the late 80s when Professor Kahn started doing transplantation here. There have been some major developments specifically in hepatology, and there have been shifts in the indications for liver transplantation. So if we think of viral hepatitis C, this can now be eradicated with direct acting antiviral agents that were approved by the FDA in 2011. Hepatitis B can be controlled with antiviral agents such as tenofovir and lamivudine. There's been a major improvement in non-invasive diagnostic methods that allow us to screen for HCC and pick up a large proportion of patients with early HCC if they are in the screening program. There's been a better understanding of the genetic basis of diseases such as hemochromatosis, alpha-1 antitrypsin deficiency, and these often can be managed with the patients not requiring transplantation for quite some time. So with this, especially in the Western world, there's been a major decrease in the need for transplantation for hepatitis C. There's an increasing incidence of patients with metabolic associated fatty liver disease requiring liver transplantation. Hepatitis B, patients with hepatitis B can now be offered transplantation quite safely with a low risk of them developing a recurrent hepatitis B in the transplanted liver. And I think, certainly for us as surgeons, the proportion of patients that are being transplanted for malignancy is increasing, and it's not just for HCC, but I think especially for HCC. And in our unit, it's one of the main indications for liver transplantation. There's two series that have been published in South Africa. The one is the Donald Gordon experience, this was from 2006 to 2018. They transplanted 31 patients for HCC, 26%. The most common indication was hepatitis B. You can see there was 10% of the patients had an alpha-fetoprotein of more than 1,000. They used the UCSF criteria, and well, they didn't use it in everyone. About 81% of patients were within the UCSF criteria, and 4 were outside of those criteria. And if you look at the survival curves, patients who were within the UCSF criteria had a 5-year survival of 72%. So, it's a very effective treatment. This is a bit old now. This is our experience. Up until beginning of, or the end of last year, we had transplanted 7 patients for HCC. We've now transplanted 9. We've now had 1 death. At this stage, we hadn't had a death. One of our patients died after 6 years, but not due to recurrence of HCC. So at the moment, looks like we're going to have a 5-year survival of close to 100%, which you can say is good, but it also suggests that that we are being too selective in who we choose for liver transplantation, and that we are missing patients who would benefit from liver transplant. And tying into that, if you look at, this is data that Gareth Chilton, one of our registrars, published in his MED. From the 1st of July 2015 to the 30th of June 2020, 152 patients with HCC were referred to our unit, and only 21, so that's 13%, were treated with curative intent. 86.2% were treated with palliative intent. And I think that there are some patients in that group who may benefit from transplantation. So how do we increase the number of transplants for HCC? So in our setting, I think the main thing at this stage is to change the indications. We need to try and increase the potential transplantation. Well, we need to do that without compromising on outcomes. So increasing the number of patients who are offered transplantation, but without compromising on outcomes. We don't want to invest all of these resources in patients who don't do well. At this stage, we actually have more livers available to us in Cape Town than we use, and we send livers up to Johannesburg fairly regularly. But if we did become busier and we started using all the livers that we have, we'd have to increase the availability of organs. And one of the obvious ways to do that is to start doing living-related transplants, and that's something that Tinus is going to speak to. So if we look at how the indications are changing, this is the Barcelona Liver Clinic staging system that was updated in 2022. And I'm not going to go through all the things that have changed, but one of the big changes when it comes to transplant is that they now acknowledge that there are proportions of patients with intermediate stage or stage B cancers who do benefit from a liver transplant. So before, it was only patients with very early stage disease, but now you can see here, they say extended liver transplant criteria, patients may benefit from a transplant. So what does that actually mean? So if you look at the traditional, most of the transplant criteria that have been used, and that started off like the Milan criteria and the UCSF criteria, were based entirely on size and the number of lesions. And that was just something that was, it was validated after those numbers were chosen. And we know that this whole metro ticket concept developed, that as you go up with the number or size of lesions, you pay a price with a decreased survival, okay? But I think that this whole metric ticket concept is too simple. And one of the things that proved that was the Toronto criteria, which are at the bottom of that table. And you can see any size, any number, but not high grade on biopsy. So in Toronto, if you're within Milan criteria, you get a transplant. If you're outside Milan criteria, and on the biopsy, you've got a well-differentiated cancer, then you also get offered a transplant, even though you're outside Milan criteria. And the survival is not that different for patients who are outside of the Milan criteria. So there's a paradigm shift occurring, and there's a realization that morphological criteria are not a good indicator of tumor biology. And if you just rely on that, you exclude a proportion of patients who will have good outcomes with a transplant. And I think biological criteria are as important predictors of survival. So I don't think the morphological criteria are going to go away completely, but I just think that they shouldn't be the only criteria that we consider. And if you think about it, the size of a tumor is not just a function of how quickly it's growing, but also how long it's been there. So if you I think this paper describes it well if you want to go and have a look at it. But like I said, size does not equate to bad tumor biology. And they go through 5 factors that are associated with bad outcomes, and suggest how we might pick patients who are outside Milan or UCF criteria, but still have good outcomes. So if you look, I mean, I think extrahepatic metastases are generally considered a contraindication to transplant. But then the other one is macrovascular invasion. And it's not as simple as just invasion of the portal vein. Invasion of the main portal vein does have the highest risk of recurrence. But if other factors were good, you might consider it still with having good outcomes. And certainly invasion of branches of the portal vein do not have as bad a prognosis as invasion of the main portal vein. The next thing that is associated with bad outcomes is progressive disease despite local regional therapy. And the other thing is too short waiting lists. So I think if you progress after local regional therapy, there's a 5 times increased risk of recurrence. So in our transplant program, every single patient that we've transplanted has had a TACE, and we've never transplanted someone who's progressed on chemoembolization. And I think, if you have someone who's intermediate stage disease and they have a very good response to local regional therapy, that is one of the things that I think you can use as a surrogate for predicting good outcomes. Another thing is not rushing to do the transplant. If you look at units that transplant patients very quickly, like within 3 months, and you compare them to patients who wait longer than 6 months on waiting lists, patients who wait longer than 6 months, on average, those units have better outcomes because the patients with aggressive disease have enough time to progress while they're waiting for a transplant. So that's one of the reasons why patients only get MELT points after waiting 6 months. And I think it's not good to rush transplantation in patients with HCC, especially if they're beyond transplant criteria. You want to see that they respond to the local regional therapy. The next thing the next thing is the presence of microvascular invasion or poor histological differentiation, and that ties in with the UCSF, the Toronto experience. If you have microvascular invasion or poor histological differentiation, that's associated with poor outcomes, and so is a persistently elevated alpha-fetoprotein. If your alpha-fetoprotein is more than 1,000, you have quite a high chance of getting a recurrence. And if you can get that to below 400, you have much better outcomes. And if you transplant patients who have alpha-fetoprotein or less than 100, your 5-year recurrence-free survival is less than 97%. One of the problems with doing a biopsy is that you may have, if you've got multiple tumors, one may be poorly differentiated, one may be well differentiated. So you're not sampling the whole spectrum of disease, and that's where a FDG PET potentially is useful. It's been shown to be very good at, so usually FDG PET or patients with, I think I'll talk about that on the next slide. Let me just see. Yeah, so hepatocellular carcinoma generally presents with a low avidity on FDG PET, and increased uptake on a FDG PET relates to more aggressive biological disease, microvascular invasion, poor differentiation, and higher post-transplant recurrence. So I think an FDG PET is a good way of assessing, another good way of assessing transplant biology, and something that should be considered if you're considering transplanting patients with more advanced disease. So that same paper came up with this diagram that I think is quite useful. So, if you've got a patient with early stage disease and without any of the risk factors that we spoke about, you should probably proceed with liver transplantation. If you have a patient with intermediate stage disease, you can consider them for transplantation, provided you've dealt with these risk factors or they're not present, basically. So I think, the morphological criteria need to be considered in the context of all these other biological factors, which does make the decision-making for transplantation a lot more complicated. So this is my last slide. So basically moving forward, I think we need to increase potential candidates for transplantation. And the 2 ways we can do that is by screening high-risk patients, but also shifting away from morphologically based criteria. And then the other thing we need to do is increase access to transplantation, which is something we've spoken about a lot on this forum. But what we haven't spoken about a lot is living-related liver transplantation. And I think that's even in the West, where there's lots of donors, as transplants get done more for oncological reasons, the only way we're going to be able to have enough organs is if we do living-related transplants. And I think in Africa, one of the only ways we're going to start doing lots of liver transplants is if we start doing liver-related liver transplantation. So thanks very much. I don't know if there's any questions after all of that. Can't actually see the chat. I'm going to stop sharing. Doesn't look like. So, Tinas, do you want to, oh, sorry, there is Sianda.
Hi, thank you for a great talk. I heard you mentioned that in Cape Town you've got more livers that are available. Is there something that you're doing that's different from the rest of us in the country, or what are the factors?
I just think we don't manage to find the patients to transplant. We don't have a good referral base. I don't know what the answer is to that. Tinas, I don't know if you want to say something about that.
Hi, Mark. Yes, and thanks for the question. We do put a lot of resources into, going to do talks at hospitals, making sure that there's a good donor referral base whenever possible. So I think in the Western Cape, Eastern Cape, there are quite good deceased donor referral structures. But still, as Mark says, I think that the main consideration is that for some reason, we know the recipients are out there, but they just struggle to come through the system in time. We see a lot of patients who could have benefited from liver transplant 6 months or a year ago, or even longer for that matter. So I would say certainly more a recipient issue than a donor issue.
Okay, thank you.
So we want to stop being a net exporter of livers to Joburg. Tinas, do you want to share?
Sure. All right. I hope everyone can see my screen.
Yes. Yes, we can.
Yes. Thanks, Mark. So Mark asked me to just give a bit of feedback about the experience in Turkey. I'll also just give you a bit of background information about myself and the unit. So I'm a general surgeon. I've worked in the transplant unit for about 10 years now, and as a consultant for about 8 years. We have a kidney transplant unit that perform between 50 and 60 kidney transplants a year, and we perform those from deceased and living donors, about half, I would say. And as Mark mentioned, we've got a very established, or at least a liver transplant program that was established a long time ago in kind of the late 80s. But it has never really been a high volume center. I'll show you a few slides, and at its peak, we were performing 15 liver transplants per year, and that has now dropped to about, I would say, less than 10 a year for the recent past. So naturally, we would like to kind of boost our numbers for different reasons. Firstly, I would say that it makes it much easier to motivate and ensure that you have good staffing available. If you're doing 10 liver transplants a year, hospital management and whether you work in public or private, they find it very difficult to commit human resources and other resources to a low volume center like that. So that is kind of the first motivation. Secondly, we want to see all the patients who could potentially benefit from transplantation being transplanted with good outcomes. And that you can only do, like with any major surgery, there's a very kind of close collaboration between the number of operations that you do and the outcome that you can achieve. So, although Marcus mentioned that we have a net surplus of deceased donor livers, that is not always true. We do go through quiet periods. We do go through periods where there are quite a few patients listed, or when there are urgent patients listed. And, for that reason, living donor liver transplant was worth exploring for us. So I just want to give you an overview. Globally, the average liver transplants are around about 5 per year. And you can see that in the Americas and in Europe, the numbers are kind of 11, 12, 13 per year. And one has to accept that in those areas, the healthcare systems are very well established and developed. Yes, they have their problems, but one would think if you also include patients who have died on the waiting list, this number around about 12, 13 should be quite close to the actual need for liver transplant, worldwide. We do accept that etiologies differ from one region to another, but I would say if you include patients that have died on the waiting list, you're probably looking at an average of 15 liver transplants per million population that everyone should be doing if we're getting things right and if we are identifying potential recipients, all the potential recipients. So you can see on the left-hand side, maybe you can see that Africa is actually really struggling in terms of the total number of liver transplants being performed. So these figures were all reported to the Global Observatory on Donation and Transplantation. This was in 2018. And at that stage, there were 3 main countries performing liver transplant in Africa out of the 54 countries. So Egypt, definitely the leader. Also, a lot of living donor programs going on there. In South Africa, we've got 2 centers, Wits Donald Gordon in Johannesburg, who is a high volume center with both deceased and living donor. And then in Cape Town, we have 3 centers, but we kind of see ourselves as one center. We've got Red Cross Hospital, so that's pediatric liver transplant, Curtis Care public sector, and UCT private, where we assist with private liver transplantation. So this is a very nice snapshot of liver transplantation or the history of liver transplantation in South Africa. There were 1 or 2 performed in the early to mid 80s, but things really took off from 1988, sorry. And as you can see, at its peak, we performed 15 liver transplants in 1994. At that stage, as Mark alluded to, there was only 1 liver transplant center in South Africa. So that meant that all the deceased donor referrals and recipient referrals came through the center. But still, we couldn't really provide a service to patients upcountry, patients whose infrastructure and support structure was based up there. It didn't make sense to send patients 1,500 kilometers to have a liver transplant done. So because that need in Johannesburg could not be met by a single center, in 2005, they opened the liver transplant unit, and immediately you can see that there was a significant need for this operation. And then in 2013, the volume just continued to climb. That was when the living donor program opened up. In the mid-2000s, there had to be a discussion about drainage areas, both for recipients and for donors. And although it was divided equally in terms of surface area, when we look at it from a population density point of view, the Western Cape, Eastern Cape, and Northern Cape are only really responsible for 25, or only represents about 25% of the population. So, if we function at the same efficiency than Wits Donald Gordon, which is essentially a private institution, we would be performing a quarter of the transplants they perform. And this is just another kind of way to look at it. And you can see towards the north and the east coast of South Africa, it is quite densely populated. So, I mean, if you break it down into really simple terms, then the basic prerequisites for a successful liver transplant center is you must have sufficient donors, you must have sufficient recipients, and the adequate resources. And if you have a relative excess of one of those, it's not really going to impact on the number of transplants or the quality of the transplants that you can do. And, vice versa, if you have a relative deficit in one of those, you cannot really function optimally. So as we said, with regards to donors, there are ways to kind of get around it. I've got a slide a bit later on that we can talk about, but even in the African situation and in Africa, we can consider DCD when there's no brain death legislation or living donation. And as a surgeon, what we can do is make sure that there are adequate donors for the patients being referred, and we can lobby for resources. On the recipient side, with regards to malignancies, certainly, those patients come through our clinics and come through our practices, but, predominantly in South Africa, we are still reliant on, medical gastroenterology, a good medical gastroenterology service to refer those patients. So we did say that we are net exporter of livers, and that is true, but in the Western Cape specifically, and we have always prided ourselves on good deceased donor referral base and a good deceased donor program. We certainly have seen a drop in our deceased donor numbers recently, and that was even before COVID hit South Africa in 2019. So, another reason to just not only rely on deceased donation, but to look a little bit further. Often when you go to international conferences, there are lots of talks on expanding the donor pool, from ABO incompatible transplants when it's necessary, to splits when a donor is suitable for a split, donation after circulatory death. And in Europe and the US and Canada, there are lots of centers making use of ex vivo machine perfusion to resuscitate extended criteria donors. But the only two that you can really get more access to better quality livers would be living donor liver transplant and splits. We have, from Red Cross, we have sent quite a few patients to Witwatersrand Gordon over the last 7 or 8 years. I think it's about 20, and mostly for acute indications. And these patients were very quickly transplanted with living donor transplants, which is a life-saving, treatment option for these kids. We've supported that, especially during COVID in 2020. You can see that a lot of the patients went up to Witwatersrand Gordon as most of South Africa discontinued deceased donation, but living donors were still going ahead. So there certainly is a need for living donation, even if it's just in the pediatric population. So the rationale for living donor in Cape Town, it would be a mechanism for an already low volume center to maintain recipients from within our drainage area, and to offer patients, liver transplant where the existing support structure is in place. As I said, we have essentially one permanent post in transplantation, but we cannot do this without the support and expertise from HPB surgery, hepatology. There are just a massive amount of people who dedicate time when a liver transplant has to be performed, and that makes it much more attractive to offer liver transplant as an elective procedure, so everyone can arrange accordingly. There's also potential to make use of liver transplantation in an urgent situation. It's always going to decrease time on the waiting list, which will always have benefit attached to it. There are some authors who have reported better outcomes in pediatric recipients. Obviously, those are in medium or higher volume centers. And there's also a potential to offer living donor when the patient does not fulfill your center's criteria for a deceased donor liver transplant. So in kidney, we would very rarely offer living donor kidney transplant to a patient who does not qualify for a deceased donor transplant. But the kind of the ethical argument about that is, or around that, would be that you can offer the patient dialysis, which is a very good replacement of transplantation, and we do not have that in liver transplantation. So you can certainly, if a patient, if your criteria is that we only list within Milan or UCSF and the patient is just outside, you've got willing family members who are informed, you certainly could make a very good argument for performing living donor transplant in those patients. It's always also a way of offering liver transplantation to international patients. Yes, there are still some legislative things around that, but much less so than performing a deceased donor transplant for a patient who's not a South African citizen. And there are lots of positive impact on deceased donor liver transplant program that I will discuss just now. So long story short, I went to Turkey for about 6 months from October last year to April. The hub of living donor transplant in the world, I would say. They perform 1,500 liver transplants a year. Of those, about 10% are pediatric liver transplants. So by far, predominantly adult-to-adult living donor transplant. 90% of their liver transplants are from living donors. And in the time that I was there, to give you an idea, we performed 50 living donor transplants and only 2 deceased donor transplants. So that's the ratio that they're dealing with. This is the hospital that I went to. It's a private hospital group, but it's a teaching hospital on the kind of west borders of Istanbul. So a wonderful environment. Unfortunately, it was during winter, but it was still beautiful to do sightseeing there and all the rest. We also had 2 of our anesthetists come and join us for 2 weeks, and Mark also joined for a week. And you know, it was just a wonderful experience to kind of be able to share that with colleagues and have discussions about what is appropriate to apply in our situation and what is not so appropriate. So it's a private university hospital, 260 beds, 28 adult ICU beds, that is not dedicated to transplantation, 15 pediatric ICU beds, 20 transplant ward beds. And they are quite dependent on nursing staff. A lot of the transplant ward is essentially run by nursing staff, very, very well-trained nursing staff with bi-daily ward rounds from the surgeons. This is the surgical team. So Professor Yaman Tokat is kind of one of the living legends of liver transplant in Turkey. They were very accommodating, very friendly, and really made you feel like part of the team. So we did 50 living donor liver transplants. 45 of those were right lobe, 1 left lobe, and 4 left lateral segments. So of course, 50 living donor transplants, 5 adult to child, 2 deceased donor, and 1 donor transplant from a child with methylmalonic acidemia, and a variety of liver resections. The donor outcomes were essentially very, very good, as you would expect. There were no deaths or need for transplant. There was one intraoperative issue, quite a major complication with a right posterior sectoral duct that was draining into the left that was ligated during mobilization of the left liver. This was during the full left lobe. And minor complications, I didn't really specifically have access to that data, but in the literature, the minor complication rate is reported to be 20 to 25%, and readmission rate at about 6 months is about 10%. There were 3 patients who had MRCPs within the first week after donation. They had a very low threshold to do an MRCP, even though the post-resection cholangiogram was reassuring. They would do an MRCP with a very low threshold, and 2 of those patients underwent ERCP, but none of them had biliary stricture, and no further intervention or operations were necessary, and they stayed about between 5 and 7 days, I would say. So this is, I think, the cholangiogram that was done on initial exploration of the donor. You can see a left posterior sectoral duct, and unfortunately it's been ligated at that specific area. The duct was re-anastomosed, and the patient did well, did not have any early complications. So what do we expect biochemically after doing a major resection in a patient with a completely normal liver? So I suppose not unexpected or not different from major liver resections. By about day 3, you would expect the total bilirubin to start to divert downwards. The AST would peak, the AST and ALT would peak at about day 1, and then will quite dramatically decrease. And then the gamma GT and alk phos would just do it like 6 hours and 12 hours post-op, and then only on follow-up day 7, day 8. And the gamma GT and alk phos will continue to rise up to about 30 days post-transplant because of regeneration. Recipient outcome, there were 2 patients who passed away in hospital. One was a very high MELD score patient who was quite coagulopathic intraoperatively, had to be packed, went to ICU and had to come back for a relook early morning hours. A bleeder was oversewn, taken back to the ICU, but just from a metabolic point of view, was not very well preserved, and unfortunately, continued to be hypotensive, ultimately thrombosed the artery, but I think that was just a part of the terminal event. And another patient, so the 2 deaths. And then hepatic artery thrombosis, the one was the patient that I referred to now, and then there was a pediatric liver transplant that also had a hepatic artery thrombosis at about day 5. Portal vein thrombosis, 1 non-occlusive thrombus that was revised surgically. There were no retransplants, about 4 relook laparotomies, 2 for bleeding, 1 for the portal vein, and 1 hepatic artery thrombosis that was revised. Biliary complications, so they have an external biliary drain protocol where they would leave an external biliary drain across the anastomosis, and at 1 month they would do fluoroscopy, make sure that everything is still patent, and at 3 months that external biliary drain will be removed. So it was quite difficult for me, especially during the short stay, to kind of get an idea of exactly what the biliary complication rate was in this specific center. We know it's kind of the Achilles heel of living donor transplantation, but they kind of temporized it with external biliary drains and then would manage most of them endoscopically. The right, because it's adult to adult, obviously the right side was used most often, and they preferred a modified right lobe. So the middle hepatic vein would stay in the donor, and if the segment 5 and segment 8 veins were 5 millimeters or bigger, that it would be reconstructed on the back table. So the impact that I think a living donor liver transplant program or exposure to a living donor program can have on a deceased donor program would be that you would be much more comfortable in splitting in situ or ex situ and reduce grafts deceased donor livers. It's certainly more anatomical to do it in situ, and you can expect perfect gut surface hemostasis, and you could potentially decrease the rewarming on the back table and the cold ischemic time by doing that. And some authors have reported better outcomes versus ex situ, although I know in Johannesburg they did a study comparing in and ex situ and didn't find any difference. You certainly will have a much broader familiarity with the anastomotic techniques used to anastomose very small arteries and bile ducts. And potentially, because of the time frame that you could offer liver transplant, you can expect to see more recipient referrals. So yeah, just a few pictures. This is Utku Yilmaz. Is a wonderful surgeon, very friendly, and really made me feel at home. And he was the donor hepatectomy surgeon. And what started off as initially an observership, they kind of drew me in, and I'm eternally grateful to them. This was the anesthetist and a few of the scrub personnel.
Thanks very much, Tinus. Are there any questions? Just a comment and when I was there, I was just struck by how organized everything was, and like you say, what good surgeons they are. The other thing that obviously stands out is how nice it is when a transplant becomes an elective operation. But when that becomes important is, I think, especially when you start transplanting for malignancies, and if you're going to start transplanting for colorectal mets and things like that, it's really nice to know that you can do it sort of when it's the most appropriate time. Yeah.
Yeah, exactly. To fit into the chemotherapy window,
Yeah.
and you know, it's just so much optimized. And also transplanting at lower MEL scores. I mean, that is also something that struck me. Yes, they have the odd late referral. I'm not sure if I mentioned in the talk, but they do. About 20% of their patients are from outside Turkey, or international patients, and many of them have been, you know, drifting around and not really, you know, certainly not early referrals, or they've been saving up money to come to Turkey or something like that. So they certainly have been, you know, high MEL score patients, and you're always going to see them. But ideally, you know, this operation should be done at lower MEL scores.
Yeah. Any questions? I was trying to see if anyone's got a question. Okay. All right. So, I mean, Tinas, my view on this is that I think over time we're going to start doing much more transplants for oncological indications, and the only way that there will be enough livers is if we start doing liver-related liver transplantation. So, I mean, I think, you know, I actually think that's the way things are going to start going around the world, except in a very few places where there's really a lot of livers.
Yeah, I agree. And I think we just need to, you know, it's very resource intensive, but it's easy to plan. And,
Yeah.
you know, I think over the next 6 months or a year, we just have to kind of, you know, build towards that.
Yeah. Okay, thanks very much. That's a good talk. Sorry, there's a question. Is the donor liver harvested laparoscopically or open, Rashid?
So at that center, they perform open donor hepatectomy. They do not really perform laparoscopic liver resections for, you know, HPP indications. But the donor surgeon that I worked with has started robotic hepatectomy training. So I think they want to go straight to robotic. Yeah.
Okay. Any other questions? If not, I think we'll move on. Nicholas Leach is a fellow in the transplant unit at the moment, and he's just going to present a patient that we discussed at our MDT last week, and I'd appreciate people's thoughts and opinions on it. Nick?
Cool, thanks, Mark. Let me just try and share my screen quickly. Coming up.
I'm not seeing it. It does say that you started sharing. Otherwise, what I can do, just try again. Otherwise, I can share it.
There, it's up. It should be up.
I'm not seeing it.
It's not showing it.
Nick, it does. I'll tell you what I'm going to do. Oh, there we go. Now it's showing.
Okay,
Yeah.
here we
There you
go.
go. This might be my signal.
Okay.
Thanks. So I'm going to be just presenting a case, Mr. MDJ. He's a 63-year-old gentleman, background hypertensive, diabetic, and with dyslipidemia, reasonably well controlled on single agents for each of those comorbidities, and with an elevated BMI more than 30. He was diagnosed in November 2022, November last year, with cirrhosis and portal hypertension. And the suspected etiology was either or a combination of MAFLD or an alcoholic sort of liver disease. But on presentation, he still had preserved liver function. And on further investigation, he had gastric varices, but never suffered from any variceal bleeds, and also had evidence of portal vein and SMV thrombosis. And then earlier this year, sort of he was being screened due to unintentional loss of weight, and was diagnosed with an HCC and had a TACE in February this year. And now recently, on further surveillance, he's been found to have a new segment 7 lesion, and then was brought to our MDT. So just having a look at some of his results recently and his background. So his performance status of around 1. He's a child Pew A with a score of 5. He's a MALD 11, and on a Barcelona liver, he's a stage A. Just the one thing is AFP was never really elevated, and throughout serial testing was always less than 2. I may have some difficulty showing the imaging, so I just want to run through some of the summary of the imaging findings. And it's this new segment 7 lesions. It's around 21 millimeters in diameter. There was no obvious visible washout, and there was only slight capsular enhancement on the portal venous phase. So it was scored sort of as a LIRADS 5 or LIRADS M, and the differential was either cholangio-CA versus an HCC. Another comment they made was that there was possible intercostal access for microwave ablation, but the concern was that the lesion was quite close to the right hepatic vein, which might cause some difficulties. Other finding was that he had some smaller cysts in segment 6 and 7, some quite profoundly enlarged portosystemic collaterals, and then splenic vein wall calcifications, which might be an indication of chronic thrombosis. I'm just going to see if these videos will play. Is that coming through all right?
It's coming through. There's a bit of a delay.
Okay.
Otherwise, Nick, I can try and show it.
Let me see. I can play the videos. Maybe it's better.
Yeah. No,
It's not coming up.
Yeah, let me
Yeah,
show
Mark,
it.
if you can, I'll stop sharing.
Yeah. So stop sharing. I'll
Sure.
share. Let me just see. Okay. Hopefully it works here. I'm just going to go to it. Sorry. So I don't know if this is playing. This is the arterial phase.
It is playing.
Okay. So there's the lesion. And you can see how it's situated between 2 branches of the right hepatic vein. This is the 5-minute delayed phase. It does wash out a bit with the capsule. My understanding is that the radiologists, I know what you said when we reviewed it, they thought it was a LIRADS 5 lesion. The one confounding factor is on the CT scan, which you can see here. If you have a look at the portal vein, there's a non-occlusive thrombus that's probably occluding going right down into the SMV, probably about a 30 to 40% occlusion. So, the question was, would he do well with a transplant? I don't think resection is a good option for him because it would be quite a big resection because we'd have to take the right vein. I worry that he would decompensate, and he has massive esophageal varices. So though he's never had a bleed, he does have portal hypertension. So it sort of contraindicates a big liver resection. So we discussed it, and Atinas, you might have some comments also. The problem with the transplant in him is the increased risk associated because of the portal vein thrombosis versus us doing another taste and maybe trying to combine that with the microwave ablation, but the risk of obliterating the right hepatic vein, but I'm not sure that is such a problem. I don't know if anyone has any thoughts on what the best way to proceed is. Tinas, your thoughts on the portal vein thrombosis?
Thanks, Mark. So because the portal vein thrombosis extends into the SMV, obviously it's of concern in terms of transplantation. but it's non-occlusive, as you said, and there are different options that one could consider. Should you find that intraoperatively, then you can kind of make a plan. But if you know about it beforehand, especially if there is an alternative curative option for him, I would prefer to anticoagulate. Yes, there are risks in terms of the varices, and we've had that discussion. But it seems like there is some literature to suggest that if you haven't had a bleed from varices and you've got liver cirrhosis and you're being anticoagulated, that there is not an increased risk of mortality. It's mostly the patients who have had a bleed previously that you should be really, kind of wary about. So I think for him, if one could offer him microwave ablation with curative intent, and if that doesn't work, then one could offer him transplant down the line, but at least you would have had 3 or 6 months or even 9 months of anticoagulation on board.
Thanks. So Mzamo Mbele has asked, and I think it's a good question, could you consider repeat TACE and biopsy? So I think a repeat TACE is a good option. Nick mentioned that there was some question about a MET or LIRAD M. If there's any doubt about it before you could consider doing a biopsy. I mean, the other reason to do a biopsy these days is to assess the grade of the tumor. It's quite a difficult place to biopsy, but if you're going to microwave it, you're going to stick a needle in there anyway. So I don't think it's wrong to biopsy it. I'm not sure if it's going to change the management that much. And then Wanga's asked the question, Wanga Mtsankulu, our fellow, does splenic vein thrombosis preclude transplant? Tinus?
No, not if the SMV is patent, then you can definitely perform physiological portal vein to portal vein anastomosis.
I mean, there's even descriptions of patients having transplants where, me and Tinus were discussing this the other day, where you use the left renal vein to anastomose to the donor portal vein. I mean, we haven't done that. Tinus, I mean, like your thoughts on...
He does, I have reviewed his imaging. He does have a very large splenorenal shunt. It's about 10 millimeters, if I remember correctly. So that can certainly be used and it can be quite physiological in the end. The problem with the less physiological options of portal vein inflow in the transplant situation is like the hemiportocaval transposition, things like that. The patients suffer tremendously with ascites and all those kind of problems afterwards. So it's not really a road that you want to go down if you can avoid it, and you definitely want to look at physiological options ideally.
I'm not sure if there's any other questions. If there aren't any other questions, I'd just like to thank everyone for attending the meeting, and thanks very much to Tinus and Nick. Yeah, sorry. So yes.
Good question. Can you make an osmosis into a big varix?
Sorry, and that for a transplant.
Yeah.
I don't know if anyone's done that. I must say I would be very nervous about doing that, but I know that Professor Buerta, who used to work at Donald Gordon, used to say that if you're doing a shunt, like a portosystemic shunt, you can use any varix that you find to anastomose to a systemic vein. If it's big enough, if it's big, it's likely to be beneficial to do that. I think it's the same thing that Tina said. You run the risk of causing a lot of problems, having ascites and potentially losing the graft. So I think it's not something you would plan to do. You'd only do it if you were really in trouble.
Yeah. So Mark, I've had the good fortune or misfortune of doing it twice on a chunky varix with portal vein thrombosis, but then you have to modulate the splenic vein flow. So essentially you need to loop the vein. You then
Yeah.
pick a chunky vein, and then you loop around the splenic vein to see how it influences your flow onto the varix. And you choose the chunkiest varix, which has got the best flow when the splenic vein has been modulated. And you get very good results. We did a lot of them in the HCC patients, and it works pretty well. But the only other issue is I was at the Congress in India, the Rela Institute, about 3 months ago, with the splenic vein and the SMV and the port vein thrombosis. And the huge discussion, the Americans were, it's an absolute no to do a transplant with port vein thrombosis or splenic vein thrombosis or SMV thrombosis in combination. The Indians and the Asians, the rest of the Asians thought absolutely not. It's 20% of their bulk listed transplants. And you should really convert these patients down with TARE or further chemotherapy or more radioembolization, and then convert them and then do them. The 5-year survival for PVT at the moment with tumors is 50%.
Yeah. But you see, my concern about that is like, there's obviously, like you said, there's units like in America, they don't want to do it. And if you look, they're doing 7,000 transplants a year there. These are guys who are very experienced with doing transplants. I would be very hesitant to do it on someone here. And the other thing is, like we are already only transplanting, like we've transplanted 10 HCCs. It's not the kind of patient that I think we would consider for transplant. Yeah. So listen, thanks to everyone. We've come to the end of. Like I said, I just want to say thanks to Tinus. I think that was really interesting on perspective on living-related transplants, and I think that's the future for transplantation and liver transplantation in Africa. Thanks, Nick. Thank you to the ECHO University of New Mexico team and the ECHO India team. Recordings of this will be available on the Gastro Foundation website. Thank you to the sponsors. And next week it is on blood management. Thanks, everyone.